Good morning, everyone, and welcome to our Edge Talk. And we're delighted today to have Mark Britnell with us, the Chairman and Senior Partner for the Global Health Practice at KPMG. And Mark is going to talk about his search for the perfect health system. In his role, Mark works across the globe in 60 different countries, so I think that there's nobody better to be able to give us an overview of health systems. So, we know that many people are watching this live today, and others will be watching the recording, and welcome everybody. And what we'd like is for everybody to join in today and beyond today. So you can see on the right-hand side of your screen a chat box. So, when Mark's talking today, if there are themes that you want to expand or talk to other people about, or you'd like to ask questions of Mark, please put your contribution into the chat box. At the same time, we're going to have a tweet chat going on, and we're using the hashtag #EdgeTalks. So if you'd like to tweet out what you're hearing as well, we'd be delighted. And what we're going to do at various points during this morning's talk is that we'll stop and pause, and we'll see what we've got in the chat box, and we'll see what we've got on Twitter as well. We'd love it if you could join our Facebook group. So these talks are part of a global knowledge platform that our team runs, with regard to the latest thinking and practice around transformational leadership, around being a change activist. So we'd love it if you'd contribute as part of our Facebook group. And then what happens is that whenever we have these monthly Edge Talks, what happens is that each Wednesday afterwards we have a tweet chat about the topic that we've talked about. So our next tweet chat will be next Wednesday at 4 to 5 p.m. GMT around the themes of today. Just to tell you who is taking part today, my name's Helen Bevan, and I'm chairing the session. I'm Chief Transformation Officer, part of the Horizons team, which is part of NHS England. And shortly I'm going to introduce Mark, who's our presenter. We've also got some other colleagues helping us today. Janet Wildman from the Horizons team is monitoring, or is going to attempt to monitor, all the activity and the ideas in the chat room. And also we're being joined by Jodie Brown, and Jodie will be monitoring what is happening on Twitter. So let's introduce Mark. So it's interesting, so I was looking for photos of Mark to introduce him, and on the left-hand side we have the current ones, and on the right-hand side is Mark when I first met him. And I don't know if Mark remembers, but actually it was 21 years ago. And when I first met Mark, he was actually still in his 20s. And he was the project director for an amazing project at Central Middlesex Hospital, which was called the ACAD, the Ambulatory Care and Diagnostic Centre. And what was happening in Central Middlesex at that time was revolutionary. So many of the things that we do now around, extended work roles for nurses and therapists, separating out different flows, to make life easier for patients. Having single visit concepts, redesigning workflows around the needs of patients. They're the kind of things that today, every health provider does. But in those days, they were truly revolutionary. And when I met Mark at that time, anybody knew that this was somebody who was destined to be a great leader. And I think the confidence and the wisdom that we saw in Mark then, made it clear that he was going to do interesting things with his career. and I won't go through the whole of Mark's career, but he's held a lot of very senior roles in the NHS. He was the chief exec of Queen Elizabeth Hospital in Birmingham. He was the chief exec of South Central Strategic Health Authority, and he was the Director General for Commissioning and System Management for the NHS before he joined KPMG in 2009. Actually, a year before that, in 2008, Mark had prostate cancer, and he's now a trustee of Prostate Cancer UK, and I know it's a cause that's very dear to his heart. So, like, nobody has got round the world of healthcare and healthcare systems globally like Mark. So, we're thrilled that Mark can join us today to talk about his search for the perfect healthcare system. So, Mark, I'm going to make you the presenter, and yeah, really look forward to hearing your talk.
Thank you, Helen. That's a very gracious and eloquent introduction to my good morning, good afternoon, good evening to all the callers after this presentation.
Yes, Mark, can you get a little bit nearer to the microphone because there's a little bit of distortion?
Can you hear me now?
That's better.
I think everyone should go on mute. Actually,
everyone else goes on mute. That'll help.
Perfect. Well, good morning, good afternoon, and good evening to all of the listeners and participants today. Let me return Helen's compliments by saying first of all, I didn't realise it was 21 years, Helen. You look even younger than the first day I met you. And secondly, it just shows how time flies. I had the privilege, as you say, of working at Central Middlesex when we developed the first ambulatory care and diagnostic centre in 1995, and basically that sought to radically re-engineer pathways, to extend skills, especially for nurses, to standardise care, to look at efficient and lean care and business processes. And here we are now in 2016 talking about the very same things. And I want to start by that because first and foremost I'm a practitioner. Although I happen to be Global Chairman for Healthcare for KPMG and have been for the last 7 years, my heart is improving care from a patient's perspective. And as Helen said, over the last 7 years, I've had the privilege of working in 60 countries on 200 occasions. Just towards the end of last year, I published my first and probably only book called In Search of the Perfect Health System. There is a copy of it. I am not trying to get rich out of the royalties. All of my royalties go to Prostate Cancer UK. As Helen said, I survived a radical prostatectomy back in 2008, and I talk about patient power and patient vulnerability in my book. There's a chapter dedicated to it. Anyway, more of that anon. The monk, St. Augustine, says the world is a book, and he who does not travel reads only one page. I have to say, I spent 20 years working in the National Health Service, and often the limit or the extension of my interest and ability to think widely was limited to the outer edges of Birmingham or the outer edges of London when I worked in those two great cities. It is incredibly difficult to lift one's eyes when you're turning the soil day in, day out. But I've come to believe and indeed accept that this quote is absolutely true. If you don't want to read my book, if you haven't got the time to read my book, although I should say that each chapter is written in such a way that you can read it in the time that it takes to drink a cup of coffee, then I would say there are three things that you should hold on to. First of all, everybody has something to teach and everybody has something to learn. Secondly, there are more similarities than differences in global health. And thirdly, imagine the power and potential for human good if we spent as much time collaborating as, dare I say it, the communications industry, the financial sector, the defence sector, and the life science sector, all of whom manage to both compete and collaborate simultaneously. There is more that we can do, and that's why I'm delighted to speak today. And I do very much pay honour and give respect to Helen Bevan, because she has been ploughing this particular furrow for over 3 decades. Now, let me go into the presentation itself. I should say also that I had recently, at the end of January, the privilege, if that's the right word, of speaking truth to power at Davos as part of one of the 15 people that sit on the World Economic Forum Global Health Council. Now, I haven't got time today to talk about the paper that we presented with the Harvard School of Public Health, but it talks about misalignments between payers, providers, and patients. And the punchlines are that we could actually extend globally human life by 5 years on current global levels of expenditure in healthcare if we transformed more effectively. And we also estimate that healthcare is a $9 trillion industry, and about 11 or 12% of that money is being misaligned quite considerably. Therefore, of course, in these straitened times, and especially in the NHS, we are dealing with an unprecedented decade of austerity. There is still, as we know, efficiencies to be gained, and more importantly, better patient pathways and better patient care. Now, the 60 countries you can see before you, I know pretty well. I accept that I'm a little light on parts of Africa, but all these countries I visited on a number of occasions, 200 or so. So I'm working in about 30 countries a year. And because I was a former NHS management trainee back in 1990, I started my career working with the porters, with the cleaners and the cooks. And I do feel that my experience over the last 27 years has been brought to bear in this book. And of course, the hundreds of clients I now work with, public, private, and also not-for-profit. The book itself is an easy read. I don't go through all 60 countries that I've worked in. I pick 25 countries. It's actually 29 because I aggregate the Nordics. And the book really is not an academic book. It's written by a practitioner for a practitioner. And I also know that it's being read by politicians and also, most pleasingly for me, patient groups as well. I'm told by our global communications team based in Toronto that we've now sold out of the books. We sold 10,000 books in the first 3 months, so we're reprinting now. And also, I've been told that I've received over 2 billion media impressions. Now, I'm not quite sure what that means between me and you, but it sounds quite impressive. The insights of the book are obviously a product of my 27 years in healthcare. As I say, working with hundreds of different types of organisation, and also, of course, my own personal experience of running the University Hospital Birmingham, where we built, as you probably know, the single largest hospital in the history of the NHS. We were one of the highest performing hospitals in the United Kingdom. And also, as I mentioned, my experience as a patient. And of course, as many of you know, because many of you have been patients or your loved ones have been patients, you do see the health system in a completely different way when you're lying on your back. Anyway, let me now turn to the presentation itself. The book is written in 4 parts. The first part simply asks the question, is there a perfect health system? And I conclude that there is no such thing as a perfect health system, but there are brilliant examples of great health and healthcare from around the world where we can all learn from each other. All teach, all learn. The second part of the book looks at 25 countries in detail. The third part of the book looks at 7 forces that I think are at play globally, ranging from climate change all the way through to workforce. And the fourth part of the book, which is entitled We Wouldn't Start From Here, talks about the shift from healthcare in the 20th century to the pursuit of health in the 21st century. So that's the structure of the book. Now, having said there's no such thing as the perfect health system, and by the way, if I said that, you wouldn't believe me anyway. What I do then is talk about 12 facets of high-performing systems. Now, it's a subjective view. It's backed up by a tremendous amount of research. And let me just say a word on the way that I developed the book. So this week, I was working with the government of the Bahamas, helping them build universal healthcare, the first time that they tried to do that since they gained independence from the British. Next week, I'll be going to work with the Health Ministry in Israel. And wherever I go, I get briefing in 5 ways. First of all, I get briefing on the economic, social and political situation of the country. Secondly, I get briefing on the health policy and health strategy of the country in question. Thirdly, I get briefing on the health system of the organisations that we're advising or working with. Fourthly, I get verbal briefing on the characters involved. And fifthly, of course, I get briefing on the solutions that we can offer our clients. And basically, wherever I've gone in the world, on trains, planes and automobiles, at crazy times of the day and night, which I have to be honest with you, is the only benefit of jet lag, that when you wake up at 2 in the morning, you can start to write and scribble down thoughts. I have, over the last 3 years, basically been leaving notes all over the place. And 2 years ago, 2 friends and colleagues, Lord Nigel Crisp and Sir Robert Naylor, suggested that I should capture my scribbles and thoughts into a book. So I'm grateful for them, and also for John T. Rowland, who is my global executive, for helping me draft and write this book. Anyway, so the world doesn't have a perfect health system, but if it did, it might look like this. It would have the values and universal health care of the United Kingdom. It would have the primary care of Israel. It would have the community services of Brazil. It would have the mental health and well-being of Australia. It would have the health promotion techniques of the Nordics. It would have the patient and community empowerment capability of parts of Africa. It would have the research and development strength of the mighty United States of America. It would have the guile, innovation, flair and speed of India. It would have the ICT in technology of Singapore. It would encourage the choice of France. It would have the funding of Switzerland. And it would have the aged care system of Japan. Now, before I go into these countries in some detail in a second, I have to say that these are subjective observations of dealing with many clients in each of these countries. There is, of course, a lot of information around the world on world league tables, but as I say in my book, when you look at the World Health Organization, or you look at The Economist, or you look at the Commonwealth Fund, or you look at the OECD or the World Bank, each have different ratings, each have different methodologies, and each have different rankings. What is, I think, bizarre is that there are no global standards for patient experience, patient satisfaction, and patient value. And I call in my book, and also as a member of the World Economic Forum Health Council, but in the same way as we think the economy is important, so we created GDP as an indicator, we need to get together to establish and construct meaningful patient experience and satisfaction and outcome scores. And so I call for this in the book, and as far as possible, at the end of my book, I should say, en passant, we have a table which shows some of the high-level performance indicators of countries. Anyway, let me just quickly dive in now to each of these countries. Well, I'm proud of our National Health Service, and I'm not the only one. As you well know, and I talk about this in my book, in our Olympics of 2012, studies and polls took place, and 73% of the British population defined the NHS as the quintessential feature that made them proud to be British. Higher than the monarchy, higher than Doctor Who, higher than the Beatles, higher than the armed forces, and higher than the Football Association. Now, in the 60 countries I've worked in, many people are proud of their own health systems, but I've never come across a country which so closely identifies its well-being and its sense of purpose with its health system. And of course, as we know, Nigel Lawson once said that the NHS was the closest thing the British had as a national religion. And of course, that brings strength, but also brings potential weakness in its ability to change quickly. We were, after the Second World War, the country's first universal health system. By the way, the Germans had the first social insurance health system back in 1883 with Otto von Bismarck, but we were the world's first universal health system. And it is worth bearing in mind that now that we have all countries, all 192 countries, have signed up to the Sustainable Development Goals, that every country will need to have universal health care by the year 2030. Think of the battle for talent that will ensue over the next 15 years. We have to love, treasure, nurture, respect and direct our workforce because it's the only workforce we have. Now, in terms of the primary care of Israel, where I'm going next week, I believe that if Israel was based in the United States, the world would have heard of its health system. It's one of the best kept secrets in the world, as far as I'm concerned. It only spends 7.3% of its GDP on healthcare. Its life expectancy is over 83 years of age. It spends a fifth less on healthcare than other developed countries. And why and how does it do this? Well, when the state was established, in fact, even before the State of Israel was created, back in the 20s, the labor movement organized for health maintenance organizations. These both pay and provide care. And the real trick to Israel's success is that it's truly built a primary health-led system. It's got fantastic information technology. It has brilliant outcome measures for primary care. It has great community services. I was told by the medical director of Talit, which is the largest health maintenance organization in Israel, that 57% of all pediatric consultations take place on a smartphone. Now, given the conversation, arguments, discussion that we've had recently in the UK over 111, I know that HMO style or accountable care style care rooted in the community based on a strong primary care platform with brilliant ICT is the way forward. I know it's easier said than done, but Israel is a fantastic country to go and study. By the way, it has got its problems. Many of its hospitals are under pressure. It has some of the lowest bed per thousand population rates across the OECD, but it's a study, I think, for a country that one should study more carefully. In Brazil, of course, who are now experiencing big economic and political challenges, when they created their universal healthcare system, SUS, in 1988, they knew they didn't have enough doctors and nurses. And what they have done is they've leveraged the assets of the community. They have a highly geared and leveraged model where one doctor, 2 or 3 nurses, and members of the community that they have trained in certain care conditions look after about 4,000 people. They visit those people irrespective of health or wealth. They proactively prevent and they also treat. They have incredibly good statistics in terms of lowering hospital admission rates and improving long-term conditions, including mental health as well. They are the Che Guevara of healthcare, as far as I'm concerned. They're not perfect. They don't cover all of the country. There are still problems in the northeast of Brazil, but they are a phenomenal example of a low to middle income country doing the very best it can to serve all of its people through limited human resources. And we know in the West, in the developed world, how difficult it is to really activate the community. And Brazil gives us, I think, great hope and some techniques and tools to apply back into the so-called developed world. Now, mental health is, of course, as we know, often considered to be a Cinderella service. We struggle to say that one country was the best because the paucity of data in mental health is quite obvious. The Dutch provide good mental health services, and also in the UK we provide good health services as well. But in a recent OECD report of 2014, I think Australia, to my mind, is doing the best. Now, they're going through another series of reforms at the moment in Australia for their mental health service. But what's striking about Australia is their policy has not changed since 1992. In spite of their fractious, knockabout political system, they have stayed true to the course in basically decanting from mental health institutions and grounding care in communities and at home. There have been substantial investments in public promotion campaigns, great early intervention plans, and improving access through technology. They topped the OECD Better Life Index, and that's a much broader assessment of all of the factors from education to crime to social cohesion to Gini coefficients. They all contribute to the Better Life Index, and Australia is a good place to live whose government and people take their mental health seriously. Of course there's more to do, but we can learn a lot from the staying power and the consistency of Australia's attempt to improve mental health amongst its citizens. The Nordics, Scandinavia, are, I think, a great example of another form of staying power. Ever since the Helsinki Declaration in 1987, where all of the Nordic countries came together, they have consistently set about baking in and prioritising health promotion and prevention. There have been tremendous improvements on smoking, obesity and the environment. Their smoking reduction rate in real terms per annum to 2014 was 2% per annum over a 20-year period. That is a stunning achievement. How do they do that? Great relationships and coordination between the states and the local authorities, between the local authorities and the local municipalities, but also, more importantly, given in the developed world that roughly 1 in 5 jobs is a public sector job and 4 in 5 jobs come from the private sector, in the Nordics they've mobilised employers, both public and private sector, to take control and to start to help people live healthier lives. Now, this balance of public-private involvement is known as statist individualism in the Nordics. And if you have bought my book, I'd encourage you to read the chapter on this, because what they simply do is they don't have a lot of public health people just talking to each other, feeling better because they violently agree with each other's points. They take the arguments out to the employers and the citizens and the workers in the country. And I think it's a brilliant example of what you can do if a society decides to take it seriously. Now, choosing Africa for patient and community empowerment may seem very odd. Africa has 25% of the world's disease burden, but only 3% of its workforce. But it's because of that fact that, quite simply put, empowering patients and helping communities become carers is simply a matter of life and death. So what you find, and I found this in Kenya, I found this in Nigeria, I found this in South Africa, where I was 2 weeks ago, is that they train patients and members of the community in basic skills to help them face and fight both communicable diseases and also non-communicable diseases as well. If you look at what's happened in South Africa over the last 10 years, as they try to defeat or at least arrest the development of HIV and AIDS, it is not just the introduction of retrovirals or antiretrovirals, it is the empowerment of communities and also patients. And recently I had the privilege of seeing the leaders that are based in Durban fighting HIV and AIDS. And I asked them a question about what are the principles that could be applied to all long-term conditions from HIV and AIDS, and they said all of the principles can be applied to other long-term conditions. And so I think we need to, as Lord Crisp has said, sometimes learn from others that we think we have, on the face of it, nothing to learn from. We all have something to teach and something to learn. Now, I'm not recommending the fragmented health system of the United States, but I do think it's fair to recognise that it's the biggest centre for research and development in the world. It invests more in research and development than all of Europe combined. Its spending subsidises discoveries and advances from which we all benefit across the world. It has more Nobel laureates for medical devices and life sciences than any other country. And it also has some great examples of care process innovations, such as Virginia Mason, Intermountain, and Geisinger. But the point is that although America spends nearly 18% of its GDP on healthcare, and its life expectancy is 2 years less than the OECD average, we are dependent on the innovation or research flair of the US to provide cost-effective drugs. Now, having said that, and this is an interesting juxtaposition, I want to talk about the innovation flair and speed of India. So when I was in India back in October, speaking to their government, I've no doubt that India will become the generic cradle for drugs of the world. And as that happens, there will be more affordable and universal access to drugs across the world. Just one example, of course, how India took on and helped the Africans reduce and lower the price of HIV medications, for example. Now, in India, the word for innovation is jugaad, and that means make, do, and mend. It is a classic example in India of how they do three things very well from which the rest of the world can learn. Now, before I say what these three things are, I should tell you that I am personally disappointed at the progress Modi has made in implementing universal healthcare. When he was elected just a year and a half ago or so, he declared that universal healthcare would come to India by 2018. I doubt that's going to happen. We encourage their government to do more on universal healthcare, but there are pockets, often in their private hospitals, some in their public hospitals, where they do three things really well. Firstly, they standardise the clinical care process, and because they standardise the clinical care process, they can then deploy ICT in a meaningful way to role shift and to encourage the flexible deployment of skills in their workforce, which of course is limited. But those three things, care standardization, clarity of care pathways, building information communication processes on top of that, which enable the right staff with the right skills to do the right thing at the right time, often means that India, even when you compare in real terms costs, India quite often can produce care at 20% of the developed world. Singapore is a very tech-savvy state. It is also a small state of just 6 or 7 million people. It has been ranked by Accenture, that know a thing or two about ICT, as being probably the best country in the world that has fully embraced integrated technology. When I was in Singapore in September last year, I saw how the clustered approach linking hospitals with GP practices, with nurses' homes, with residential homes, is all linked and glued together with their ICT platform. They started this journey in 2004. In 2011, they rolled out the single care record, and now over 40% of all of their patients have direct access and control of their medical records. Now, we hope for the same, of course, in the UK, but I have to say that at the moment, the UK is significantly lagging behind other tech-savvy states, whether it be Singapore, Hong Kong, the United States of America, or indeed India. But Singapore is a very good example of how a full electronic health system and record can help shift care to lower cost and better settings for patients. Choice of France. France has very high levels of patient satisfaction. It also spends a lot of money, over 11% of its GDP. It has financial difficulties. A third of its hospitals are private, a third of its hospitals are run by the state, and a third of the hospitals are run by religious orders. Patients have the freedom to choose. They pay a small co-payment or deductible, which is reimbursed in many cases. Their carte vitale is their plastic credit card for healthcare. It enables them to move quickly between general and specialist care. As you know, in 2000, the first and only World Health Organization League table for healthcare placed France on top. It would be wrong to say that everything is perfect in France. It has a fairly fragmented system, but the choice of France enables patients to take control of their healthcare. And I think in terms of the choice between different settings of care, France can provide examples of what we can do when you allow patients to become more empowered. Now, when I talk about the funding of Switzerland, I would accept that this can be criticised. In Switzerland, they spend nearly as much as the United States of America. They spend 11.5% of their GDP on their healthcare. And my title for the chapter of Switzerland is entitled "You Get What You Pay For." Now, why do I mention Switzerland? Because it is it's a truism, and unfortunately, it's a fact that healthcare cannot continue to outspend its economic performance. During the last 2 decades before the global financial crisis, healthcare was expanding at a rate of 6% per annum. The global economy was expanding at a rate of 3% per annum. At some point, there is going to be a reckoning, and certainly now people in the NHS, as we know, are facing this decade of austerity. The reason why Switzerland can fund its healthcare so well, and by the way, I consider Switzerland to be the least distressed healthcare nation I have ever worked in, is because, as the World Economic Forum concludes, it leads the world competitiveness table. And how does it do that? Well, these other factors also help healthcare. It has world-class education. It has brilliant labour and workforce flexibility. It is highly effective and transparent and well-governed institutions, apart from FIFA, of course, and excellent infrastructure. So do read the chapter on Switzerland if you want to see how a strong economy can provide the basis for a strong health system as well. And finally, the aged care of Japan. We all know it's the world's oldest society, with over 25% of its population being 65 or over. I don't know how many of you know the population of Japan roughly at the moment is 122 million. It's depopulating. It will depopulate to 95 million in the next 20 years. It has laboured under stagnant economic growth for the last 3 decades. Its political system has been unstable because of the changes of Prime Minister. But, and this is the big point, and we know this very well in the United Kingdom, that Japan's politicians back in 2000 had the courage to realise that unless they spent more on their aged care, their society and their health system would fall apart and be swamped with the so-called ageing tsunami. They introduced a compulsory long-term care insurance by placing an extra 1% income tax on the over 40s. And let me tell you, it has worked. Their health systems are now much more like health communities. Their hospitals run nursing homes and residential homes. There are still big problems. They have more hospital beds than nearly any developed country in the world. But their politicians saw what was coming, and we can all forecast what percentage of our population is going to be over 65 by a certain date. And they, in spite of their economic difficulties, they decided to spend more on their aged population. They showed great respect and reverence to their elders. I have been amazed by their determination. The service is not perfect, but they did something which other politicians around the world, including the United Kingdom, need to seriously address. Because as I say in my book, we have 15 years at most to get on top of this issue, and you have to tackle the problem now if you have any chance of providing a solution later on. So they're the 12 facets.
Brilliant.
Of health systems.
Mark, hi. Can you hear me?
I can hear you.
Yeah, great. Do you know, that was like a tour de force. I just think it might be a good time now, if that's okay, to just stop and reflect. So, I mean, we're just getting fantastic feedback to this talk, both in the chat box and on Twitter. You know, lots of accolades and people really, really enjoying it. And, you know, one of the nice things that's happening is people are actually starting to share their kind of experiences and global stuff actually in the chat box. So there's a parallel conversation that you're sparking, that is, you know, really getting people to think about things. And there are lots and lots and lots of questions. So what I was going to do now, just to kind of give you a moment just to get your breath, is to hear back from Janet, who's looking after the chat, and Jodie, who's looking after the Twitter. And I've written lots of questions down as well that people are asking. So is that okay? We just do that now?
Yeah, great.
Okay, so Janet, would you like to go first? Can you hear me, Janet?
Yes, I can hear you. Can you hear me?
Yeah, loud and clear. So tell us what's been going on in the chat box.
First of all, everybody is just in awe of the book, and the reviews on the book have been fantastic. And so everybody's going to be buying that, and some people who've already bought it and read it have said in the chat room that it's a must read for quality and improvement professionals. So that's a number one. But there's a number of other questions that have come up, and Mina Mayhill, who's worked with us in the past, she's asked, how do you address GP recruitment crisis? And what's been done in Israel to attract people to work in primary care? So she's really interested in learning from the experience you've got there around what's worked in Israel.
Should we just ask Mark to answer that one?
Yes.
Yes.
Well, what's happened? What's helped Israel? It's a large number of Jewish. Russian Jewish immigrants came back to Israel when the state was created. So they have found up till now that they have not struggled to find general practitioners. However, the age profile now of those general practitioners is such that they're all coming up for retirement. So they're trying to do three things. They're trying to encourage more people to come back, the diaspora, to come back to Israel, the medical diaspora, and they've got some success in that. Secondly, of course, they are rapidly adopting technology to leverage doctor time and doctor capability. And thirdly, on the back of being tech-savvy, they're extending roles to other people, especially nurses. So they are trying to bring people back to Israel, if I can put it that way. But I think they see their solution as the leverage of medical capability through technology, because they've already grasped that there are not enough people in their country to provide all the services they need with an ageing population.
Thanks for that. And there's another accompanying question from Mark, and he says, you've mentioned the assets of many different countries, innovation in service delivery in India, harnessing industry to the cause of public health in the Nordics, great primary care in Israel. Which of these attributes do you think the UK should prioritise to make progress on?
Well, it would be tempting to say all of them, but yeah. I think right now, given the pressures in primary care, I would try and invest more in primary care. But I wouldn't do that as a silo. I think the technology play between hospitals and primary care is absolutely pivotal, because through patient segmentation and patient stratification, are devoting more time to those patients that need more time in care. I think that's really, I know we're doing it in parts of the country, but that would be the thing I would prioritise.
And there's just one last question before. Is that okay, Helen?
Yeah, one more is good.
Yeah, there's one more. Steve Fairman asks, we can't change culture and healthy lifestyles overnight, but are there any quick wins when it comes to how we can deliver care more effectively and efficiently? And I suppose this sort of taps back into some of the things that you mentioned before, Mark, but I mean, is there anything you can sort of just like top tips maybe?
Well, hello Steve, it's nice to hear from you. I personally would, and I've been saying this now ever since I was Chief Executive at University Hospital Birmingham, I would standardise care processes and hold clinicians to account for the implementation and development of those care processes. That, for me, is the single thing that we can do in the NHS if we really put our minds to it better than anybody else in the world. Because of our, I know people think the system is fragmented, but I think when we go abroad, I think we're wonderfully integrated. So that would be the thing that I would concentrate on, as Steve has been doing ever since I worked with him in South Central. Come on, Steve, try harder.
Thanks a lot. That's it from the chat room for now.
Very good. And there's just a couple more here. So one here, Mark, is from John Hunt, and he said, what is the reaction of UK politicians to the Japanese approach? Could this approach ever happen in the UK?
Well, that's a really good question. I've had the opportunity to, as some of you may know, I was on the Economist podcast last week with Jeremy Hunt, and I had the chance to discuss this with Lord Pryor as well. And of course, having worked on the NHS plan in 2000 with Tony Blair, I've had the chance over, over 2 decades to talk about the integration of health and social care. And what can I say? It's like motherhood and apple pie, everyone agrees with it. But why I single out Japan is because their politicians have the courage to grasp it. And honestly, I have talked about the need to do this in our country. We have, as I say in my book, at least now 3 failed attempts. The last was the Dilnot review, which is a pretty good review in my opinion. We are going to have to grasp the nettle. I don't think it's a vote loser. I think most people, like me, my mother is in a care home. She has been now for the last 4 years, unfortunately. She's only 71 years of age. I think most people understand that we can't go on the way we are. And I think the population of the United Kingdom will thank any politician that's honest enough to grasp that nettle. I would personally think about creating a new integrated health and social care fund, and perhaps a hypothecated insurance tax to fund that. I think that's the big idea for the next Parliament, and I hope that somebody's going to be strong enough and visionary enough to call for that. We'll see.
Thanks, Patrick. Can we move on now to the Twitter chat? I know that there's been lots of questions because I've been writing some of them down. So Kate, you're going to tell us what's been happening in the Twitter sphere.
So I think the first point I'd like to make is that actually before we even started the presentation, how people felt this was quite a timely presentation, with a lot of the in the news today about pressures on the whole hospital system with beds and the patient throughput through the care system. So I'd just like want to bring that up. I think that was a really interesting point. There's been some discussion around about commissioning, and do we think the current system for commissioning is a major problem? So I don't know if we want to have a think about that question first before I move on to the others.
Yeah, so should we start and ask that? So Mark, given what you've seen around the world, do you think that the way health services are commissioned currently in England is a major problem? And what can the world teach us?
Well, I say in my book, I don't talk about my clients because obviously all of our engagements are confidential and commercial. But with the permission of the chief exec, Glenn Mason, Glenn Steele, at the time, I go into detail of Geisinger. Now, I think the English NHS has perfect preconditions to create Geisingers in a UK context all over our country. What does Geisinger do? There are 3 parts to Geisinger. It is an integrated payer and provider. It integrates the employment of hospital doctors with primary care doctors, and it has standardised clinical processes and got a trademarked information system that looks at the 80% of the highest volumes of care, and basically ensures in real time that doctors are held to account for the performance and adherence of those protocols that have been benchmarks against best clinical and medical evidence. Now, so in a sense, without being drawn to pass comment on the current state of commissioning, that would be my answer. The answer is undoubtedly accountable care for better population health, better patient care, and better value to the taxpayer. And I see no reason why we can't do that. And to be fair, I think, to NHS England, through the innovations in the 5-year full review, we are trying to create some of those systems through the Pathfinders that and Vanguards that my good friend Sam Jones is leading. As you know, I did try in 2008 to set up a 5-year programme to develop the competence of commissioners, and then another government came along and decided to prioritise something else. I guess that's the problem with the UK. we are becoming increasingly politically centralised, and the NHS is being increasingly driven from a small centre based in Whitehall and Westminster. And as we all know, and that's why your movement is so important, you don't get sustainable change by dictating change that way. So I think I've answered your question indirectly. I see no reason why we can't be leading the world in creating a UK-style guisingers, because I believe that we want to do that, and that works with the brain of the National Health Service.
Thank you, Mark, and thank you for addressing that in the way that you did. Kate, there's some more. I know there are because I've seen them. Go on.
Yeah. So I was going to move on to the next one, which I think kind of like links into the last statement. Was what are your thoughts on the need for transformational change versus pressure to achieve cost savings? I guess it's kind of like which, you know, it's in a hard place when people are trying to deliver transformation, but they're also driven with the pressure of saving money.
Yeah. Well, I don't wish to appear to be plugging an article that was released by the Harvard Business Review at the end of December last year. But I talk about this very issue in the Harvard Business Review, about the pressure to either transact or transform. Quick definition, transact means do things better, transform means do better things. I honestly think that we're getting to the bottom of the barrel of the things that we can just squeeze out in terms of efficiency. I've read this week when I was in the Bahamas the reports of Lord Carter's review, which we helped him with. I think this target of $5 billion is largely achievable, but of course the real issue is the $22 billion efficiency challenge. I question whether the country should do that. I question whether it's possible to do it anyway. But I think the emphasis has to be more on transformation and transaction. I do believe both can be done, by the way. I think it's possible to become more efficient and more effective. But at the moment, the way that our skill set is balanced, the way that our focus is so short-term, and we've recently did a survey of 3,000 executives around the world in different industrial sectors. But in healthcare, we found that 85% of any executive's time around the world, this is in healthcare, is focused on today and not tomorrow. And that's largely because of the political or fiscal pressures affecting most systems. As we all know, I started in the NHS in 1989. You can get so far with efficiency, effectiveness and transformation. Really giving our ageing profile is what we have to spend more of our time on. How do we do that? Well, first of all, we have to have more unified executives with their objectives being unified. So we focus on just 3 or 4 things that really matter. Secondly, we do need a transformation fund. I think Simon's done well to get 1.8 billion. I hope not all of that goes to just bailing out deficits. And thirdly, you need to give time. Recently, I spoke at a Sam Jones conference where I talked about the need for skill, will, and time. And I think we need all of those 3 things. I don't see that at the moment being the paramount importance of the NHS, but it will need to be the case. I'm sorry there is no magic bullet of an answer there, but that's my impression from my experiences around the world.
And you know, what was great about that answer, Mark, without you realising it, was we actually had another question come in the chat box about Lord Carter's review, so you just answered 2 for the price of 1. So,
oh, fantastic.
Yeah, that was great. And what I'd like is, could somebody put the links to Mark's article, HBR article, into the chat box, so that people can see that. I think we should maybe just talk about, there was just one more question that I think we should talk about that came into the Twitter, which was, with so many social determinants of health in your talk, do you think the medical model of care is still fit for purpose?
Well, that's a great question. I was very pleased that the medical model of care worked on my prostate, for example. But as I say, and this is the real answer, of course, in my book, the real shift now is that if you look at the 19th century, which is the war on public health in terms of diseases. The 20th century has been a war on healthcare and medicine, and the 21st century will be the age of the individual and health. And therefore, I think honestly it's important to continue to provide treatments which are effective, cost-effective and clinically effective, but this shift to health and healthy ageing, I think, is be the defining characteristic of the 21st century. Are we doing enough? Probably not. Will technology help us in ways that we can't see or yet understand? Yes, it will. So once again, going back to where we are in the English NHS, I know my old friend Tim Kelsey did a sterling job that Connecting for Health set us back at least 10 if not 15 years. We need to be investing more in technology to move to more to promote health. The other thing I should say is I've seen employers take health much more seriously. Recently, and I think this is a plug, in Australia we bought the Performance Clinic, which works with organisations, private health and industrial organisations, improve employee motivation and wellness. The results have been absolutely fantastic. I think there's much more that we can do there with using perhaps some incentives in the future. I just don't think that we're thinking imaginatively about where people spend most of their time, which is actually either at work or in their bed.
Yeah. There were loads more questions that we haven't answered, but I think we should pause things there. Ollie Benson has put the link to Mark's Harvard Business Review article in the chat box, so anybody can just click on that and can read that as well. So Mark, thank you for answering those questions. Some of them were quite tough, actually, and I think so well. And would you like to carry on with your talk?
Of course, yes. And I'm also mindful of everyone's time. So this next slide, I'm not going to read through all 10 because we could play a game and see how many of these you could guess before I put this slide up. The purpose of this slide is threefold. First of all, you'll remember in the earlier part of my conversation, if there's one thing I can do as a member of the World Economic Forum Health Council, is I would like to create something which is a global IHI or global NHS IQ, where basically we collaborate to show and develop and spread what works. Because these 10 things, basically, this is point 2, in whichever country I go, in whichever health strategy I read, I play buzzword management bingo to myself, and I just see how many of these 10 things are ticked off. And most decent plans tick most of them off, and then this is the third point, of course, that actually it's not conceptualizing state C that is difficult, it's moving from state A to state B, which is the killer. That's my old joke, why didn't the Daleks rule the world? It was the first step that killed them. In the sense that basically we have to work much more globally together, looking at what works under each of these 10 things. And if we do that, and we start to train and develop our staff, and then hold our staff to account through the organisations that they work in and for, then I think there's a much better chance of a global shift in terms of its transformative capability. So I'm not going to read through each of these. If there's time at the end when we finish just before 11 o'clock, happy to take questions on them. But I do think, Helen, as you know, you've been talking about many of these for a long time. I think there is good improvement science evidence behind most of these, which the world should start to collaborate on. Why is it that the world can collaborate on defence systems and not on health systems? Why is it the world can collaborate on moving global finance around the world and not healthcare ideas? It's crazy. It doesn't make sense. So, 7 global challenges. There are many more, but I want to talk very briefly now about these 7. These 7 are the 7 that I bump into the most when I'm talking and working with clients and systems around the world. The first is the quest for universal healthcare. As I mentioned, the Sustainable Development Goals require now all 192 or 194 countries in the world to adopt universal healthcare. Think about what we can achieve as the cradle of universal healthcare if we work and collaborate together. And if you think about the downside, imagine what the global battle for talent is going to be like in the next 20 years. 2, innovation at scale. I have a chapter called The Paradox of Change's Continuity. I'll say a bit more about that. 3, this issue about being restless for improvement, bringing quality under control. The more I know, the less I sleep. 4, the value of the workforce. 5, patient power. I'll be talking about how when you activate patients to level 4, the highest level of activation, their consumption of care can reduce by between 8 and 21%. I know of no country in the world that will be or remain sustainable if they do not harness patient power. 6, climate change, and 7, aging. And what I want to do now is just briefly skip through each of these. Because I know most of our listeners today are from the United Kingdom, we should feel proud, of course, that we established our own universal health system in 1948. But for people who are less fortunate, three things are needed. The most important is political will, the second is managerial and clinical skill, and the third is time. And what I do is I look at countries and their systems and how universal health care has been achieved or not been achieved. And one thing I do think which is going to be important working in Africa and also India and China is the growing realization that universal health care will be provided through the telephone, through telehealth, through its links to local pharmacies, and having highly leveraged doctors and nurses in a call centre or in a care centre. And this is something which I think is going to happen very quickly now. For example, just, I hope you'll forgive me, I've been in the Bahamas this week, got back last night. They have 750 islands, population is small. They can't have a doctor and a nurse on each of those islands. They are going to provide universal health care through telehealth and telecare and leverage telephonic capability with their local network provider. We're going to see a lot more of that in the years and decades that follow. Two. This is the subject of my Harvard Business Review, and basically the question I ask is, why do people think it's so difficult to do? And I come up with three answers. The first is, most organisations think they're better than the health system they work in. Secondly, most leaders spend more time transacting than transforming. And thirdly, there is a paucity of vision with proper steps over a strategically meaningful period of time, 5 to 7 years, to enable that change to happen. And we, 18 months ago, got together 65 health leaders from 30 countries around the world, and we crowdsourced clinical directors and middle managers from 50 countries. And we asked them lots of questions, but this slide here I think is interesting. We asked the clinical directors and the general managers and the ward sisters, what is the scale of change required in your country? They said, oh, fundamental, that the health system's going to the dogs. And then we asked the same question of their organisation. You can see they were much more equivocal. Unless you have the locus of change internalised and socialised in human beings, and unless you move the focus of change from myopic transaction to, I think, broader transformation, and unless you think about population health and patient care together, you will end up doing what you've always done. And my chapter on change, ironically, says that the paradox of change is continuity and consistency of approach. And of course, for those of you who've read my book, I say that England takes the gold medal in management re-disorganisation. So we need to think carefully about that. Thirdly, this issue about control of quality. I think we're being too liberal, too laissez-faire in acknowledging and accepting the wide-scale variation that we know exists globally and certainly in our own country. KPMG did some work, and the title was called The More I Know, The Less I Sleep. We convened global conferences and caucuses around the world, got together some of the biggest organisations that have got a good reputation, for example, of course, the Mayo. And as you well know, I don't need to tell this audience that the more handoffs you have and the more freedom, individual freedom that you allow, the greater chance of things going wrong. So this movement now, high reliability organisations, is something which we don't hear that much about in the UK at the moment. It's all the flavour of the month in the US and also Canada. I believe that we are talking about it in our own country, or some people are talking about it. But I hope that NHS Improvement lives up to its name and title by concentrating as much on improvement as cost reduction. And this, in my mind, is one thing that we can do very well. I would make sure that all staff are trained in these techniques and then all staff are held to account. I don't believe that is mission impossible. And for those of you that have heard this before, I apologise, but one of my greatest cliches is that if change is a human contact sport, we best contact human beings, and we're not doing enough of that. And the reason why we need to contact human beings is because if we do not love and nurture them, then they will leave or retire. Already, the World Health Organization estimates a vacancy rate of 7.2 million workers rising to 13 million by 2035. That's before, by the way, there are only 44 countries in the world out of the 192 that have universal health care. Do you know that as Obamacare was ramping up, America employed 1.5 million more workers? That's more than the entire workforce of the NHS. There's going to be a global talent for healthcare. And that means we have to treasure and nurture and direct and support. And it means we have to think about robotics and telehealth and telecare in a fundamentally different way. There won't be enough people in the world working in healthcare to care for all the citizens and patients that need care in the next 20 years. And we did, of course, in KPMG, a great piece of research. I hope you've read it, called Value Walks. We looked at the 5 most important factors in high-performing workforce or staff organisations, and they have these 5 habits. 1, a strategic focus, an unswerving strategic focus on patient value. 2, they liberate and empower professionals. 3, they tool up and task people with business and care process redesign skills. 4, they look at outcomes, not the minutiae. And finally, they are pretty active in managing staff performance, which means that people have objectives. And they're held to account, and training development plans are built around those objectives. Their efforts are prioritised at work, their skills are applied to those objectives, and basically that's how you get staff highly motivated. And when you do, by the way, guess what happens? You find productivity improvements of about 15%. So we can do a lot more caring for our staff, motivating them properly, and directing them. Patient power, I've mentioned this, just work that other people have done. Obviously, the reference here to that great seminal piece in Health Affairs. And Paul Corrigan makes this point very well. If I was going to ask you a question and play a game, how many hours are there in a year? And how many hours does the average European citizen spend with a healthcare professional? Well, I can play this game, but I won't be able to give you any prizes. But on average, the average European citizen spends just 4 hours a year with a healthcare professional. And if you think about the number of hours that people are awake, the vast majority of their time is self-care. So it's a funny old industry that concentrates on the 4 hours and not the, in this case, the 5,800 waking hours a year. And this is what I mean about the shift from to healthcare to health and well-being. We need, I think, through technology, to really think, much more seriously about how we connect. And once again, going back to Israel, they do this really well because they're a health maintenance organisation, because they're a payer and a provider. They have every incentive and responsibility to invest in patient wellness, and they do that through technology and easy access to care professionals. Climate change, it's funny, I just got back, as I said, from the Bahamas, managed to read an old copy of the Health Service Journal. The name might have been 2 or 3 weeks out of date. But 2 things on the journal article is about efficiency in the States. I don't think you know this, but 5% of all emissions in Europe and 8% in the US are caused by the healthcare sector. So we are literally polluting the environment in which we then try and cure people with respiratory illness, for example. I don't think you know this, but if we modernised our energy facilities, our heat and power facilities, into combined heat and power facilities, which are greener and leaner, we would save a considerable amount of money. So I think this is a great opportunity here for the best of the private sector and the best of the public sector to get together. And certainly in the NHS, we could do remarkable things if we could reduce the supply chain between life science firms, because they kick out a lot of CO2. If we can think about telehealth in a fundamentally different way, we can play our part in healthcare to reduce emissions, which cause, of course, illness. So I'm not being worthy. I'm fundamentally a jobbing manager, but I have seen the consequences of climate change, and I know that healthcare can step up and do lots more than we currently do. It is our problem. I know about the short-term problems of RTT times, of waiting lists, but this is something which we should lead in healthcare globally. And then finally, ageing. You have to read the chapter for this because there isn't a silver bullet. These statistics that obviously came from my good colleague Lord Aradazi of Imperial, you don't need to be a genius to see where this is going by 2050 in terms of the number of working age people supporting those that are not in work anymore. And our work on ageing, which was commended by and run from Singapore, it was called An Uncertain Age, looks at 4 facets of good performance across governments across the world: boosting informal care and people power, harnessing technology, seeking whole of society solutions, and turning hospitals into health systems. I do say, by the way, that I believe ageing is a great sign of success in healthcare. It's also a very vibrant industry, by the way. It's an enormous industry. And I talk in the book about a conference we had in the Netherlands with bankers, industrialists, insurers, financiers, healthcare providers, tech pioneers, discussing the possibilities for the future. And I think there are many. Just one example, I think, of good practice that I've seen recently in Singapore. They've just created tax breaks for children to go and live nearer to their relatives or vice versa. I don't know if you know this, but in Taiwan, I mentioned in my book, I'm sure people in England or Great Britain or the United Kingdom wouldn't like this, but in Taiwan, children can't inherit their parents' fortune or wealth unless they've cared for them in their later years of life. I'd be interested to see in the audience here what people think of that as being the idea of the day, says him, moving on quickly. And then this is my chapter on leadership. I've talked a little bit about it, about the 85% of leaders direct all of their time at operational matters, that board leaders are twice as likely to focus on the short-term pressures than long-term changes, but healthcare leaders are 3 times as likely. I mentioned the survey of 3,000 executives. And the big issue for me is if you look at any system in the world, and it even applies to the NHS, unfortunately, but can you think of any one person in the health system that's incentivized collectively together to make that change more sustainable across the health system? What I saw in Norway and Sweden, where there's a lot of policy, a lot of politics as well, but in some of the regions in Norway and Sweden, I just saw the health and social care chief execs and their boards or organisations. They would have, say, 5 or 6 objectives each. 2 or 3 of them would be shared. So they were forced to collaborate, and then they were held to account. They had they came from different organisations, but their organisations were held to account by how well they collaborated. Their executives were held to account by how well they collaborated. Their clinicians were held to account by how well they were collaborated. It changes the human contact sport. You must contact human beings. And this is really what I talk about in this chapter. I wish we had more time to talk about this today, but we haven't. And then finally, as I come into the last lap of the presentation today, I talk about 5 forces. I am not a futurologist. I am not a clairvoyant. But these 5 things I see already. They are unevenly distributed around the world, but they all undoubtedly will play a significant role in healthcare. I'm going to briefly talk about genomics, mobile health, not e-health, mobile health, the retail revolution, the apocryphy is back, wearables, and then finally, on a happy note, end with dignity in dying. Now, we all know about this, which is the move from average medicine to individual medicine, to personalised and precision medicine. Of course, it provides great promise. Some predict now that when these tests, genetic tests, drop to under $1,000 a test, there will be a bigger take-up. I have to say at the moment, in my global travels, sadly, genomics is largely the preserve of the rich. Now, many people, including people I've worked with in the past, like Lord Crispin, Sir David Nicholson, believe, and Bruce Keir for that matter, believe that you could only have a universal health system that supports genomics because you could not have the manipulation of risk pools in the sense that once you've got a known predetermination of a potential disease, you would be uninsurable in any private system. I am very sympathetic to that argument, but at the moment I think the jury is out, the debate is ongoing. But we do know, thanks to the 100,000 Genome Project launched by NHS England, that we are right at the forefront of this, and so we should be. It's a country that has such a powerful collaboration between health and life sciences. This, of course, has been talked about already at mHealth. I'm not talking today about eHealth, but we work with clients in India now and Africa, where the model is really simple. They might pay $1 or $2 a month to a telephone subscriber. That $1 or $2 a month enables them to have access to a doctor-nurse call centre. The call centre is run by algorithms, but it does have clinicians working in those call centres. They get a device, and then scripts are sent electronically to local pharmacies. Local pharmacies provide the vast majority of primary care, and they're cutting out primary care GPs and hospitals. Now, I'm not saying that's right or wrong, but I'm saying it's happening in Africa and India, and also in China as well, although the Chinese still very much like going to get their drugs from their hospitals, because that's the way the system is, how shall I put this, incentivised. But there is no doubt in my mind that, and speaking to people in India, they believe that they can be the cradle of innovation for generic drugs, but they also believe they can be the cradle of innovation for e-health as well. I don't think simply we're doing enough about this, and I think we need to be thinking about introducing tariffs which, as a minimum, allow patients to consult with clinical practitioners on the phone. But increasingly, I think we need to make much better sense of 111. I'm not saying anything here that would surprise anybody, but once again, it seems to be a series of missed opportunities that we really could do better together given our socialised platform. Retail revolution. The reason why I said the apocryphy is back, I don't know if you know this, but the first apocryphies existed 2600 BC, and guess what they did? The apocryphies sold wine, they sold food, and they sold medications, and treated you, often, of course, with leeches. And I'm not suggesting for one moment we go back to that progressive form of treatment. But I am saying, as you can see now from the rise of Minute Clinic, Walmart, and others, that retail chains offering highly accessible, relatively cost-effective, quick and convenient treatments are growing rapidly. And, you know, given the community pharmacy debate that we have in this country, I wonder how long it is before, well, I know that supermarkets are already thinking about whether you can provide healthcare from the supermarket. I don't want to agitate too many people today, but it is one way in which we can encourage people to think about what they buy, what they spend, and how they live their lives. So I think it's certainly something which will develop in many parts of the world. So what am I suggesting? I think the retailers and the telecommunications companies are going to have a massive impact in healthcare across the globe in the next 10 years. And it will start from developing countries first. Now, I don't know how many people today have got a wearable with my iPhone. Now, of course, I'm looking for my steps per day. I'm up to 8,500. I'm determined to get to 10,000. So I know it works for me. But is it a fad for the very well? Is it a fad for people like us? Well, yes and no. We do know already that tracking devices are helping people with cardiac problems across the world. We also know in its own right that the market is worth $737 billion by 2018. I'm cautiously optimistic, but still slightly sceptical that we will break through soon about wearables. But I do think for certain diseases and conditions, it enables us once again to make patient-powered care or people-powered care a reality. Now, I don't want to end with this. I have got one more slide. But, and we do know actually that looking at some of the reports that recently came out by the OECD, and I think the World Health Organization, that Britain does better than most countries in dignity and death. But guess what? We know that we don't do very well. I think this issue about dignity and death, of course we can save money, but it's really about dignity. And it's actually a test of how well the health system puts patient and carer needs at the centre of decisions and not at the periphery. And I say in my concluding chapter that how we care for the dying is the litmus test of a good health system and a responsible society. We can do much more. Our use of palliatives is poor, it is skewed to the wrong people. And of course, I mentioned 12 Gandhi's inspiring book, Being Mortal. I conclude by saying that death, like life, requires a different collaboration of the willing between practitioners and patients, communities and carers, societies and providers and payers as well. I believe, I hope in my book that it is possible to draw inspiration from different great examples of health and healthcare around the world. It's all about the context. But as I say in my concluding, in fact it's my the last words in the book, from the first female Nobel laureate ever, Marie Curie, nothing in life is to be feared, it is only to be understood. Now is the time to understand more so that we may fear less. And there is a lot of fear in our country at the moment, whether you're a clinician or a manager or a patient or a taxpayer. But by helping to understand what goes on in the world, we can gain perspective, we can deepen our understanding, we can forge better collaboration, and together we can improve population health, patient care, and better value as well. So it's now 10:52. I know we're closing this session at 11 o'clock. That's all that I would like to say by way of my book. I hope that you buy it. It goes to a good cause, Prostate Cancer UK. It's sold out, so bear with us. I think the print runs are being made now. And Helen, I'm very grateful for you to invite me this morning. Look forward to questions now and observations. Thanks very much indeed.
Mark, that was really amazing. It was a tour de force, because I said to you earlier, oh, we'll stop every 20 minutes or so for questions, but I just didn't want to stop it because, I think people were so engaged in the listening, and I think it takes a great orator to be able to do that, and particularly to be able to do that virtually. And so what I was going to do now, just really quickly, was to ask Janet, do you want to give us a bit of a review of what's been happening in the chat, and Kate with what's been happening in the tweet box? I hope we might just get one or two more questions in. So we'll do it the other way around this time. Kate, what's been happening on Twitter?
Hello. I think a lot of the conversations kind of shifted actually to the chat box because it's hard enough, the number of characters, but we've got some questions about the slide about the solutions and about how much of it can we relate to or apply to the UK healthcare system. I think that's quite a good question. So then if you want to answer that one first.
So the question is, in terms of, Mark, and what you've seen around the world, how much of it is truly relevant to the UK system?
Honestly, nearly all of it, because I make the point of the thought that we're all human beings. We basically die of the same things. It's just a question of when. So honestly, like anything from ICT, process of design, the motivation of clinicians, the education development, research. There is so much that unites us as a human race working in healthcare. Of course, the challenges in Africa are different to the challenges in America, but there are so many things that we can collaborate more on, and that's why, without flattering you, Helen, I know you do your very best to make sure you bring the global community together. So do the IHI. I think if we can actually, I don't know why, and I hope that through the World Economic Forum I can get people to say, in the same way we've got a World Health Organization, we should have a World Change Organization, or a Healthcare Change Organization.
Yeah, I absolutely get it too, Mark. And the great thing is, in the same way that you talk about the opportunities that technological advancements give us in health and care, the same technological advancements enable us to connect with each other as a world health and care community and learn from each other. So, we haven't got, because we did this call at 9:30 in the morning, we haven't got people on it live from the US or Canada or Australia or New Zealand, but lots and lots of people will be listening to the recording, and we can connect all over the world in ways that we couldn't. And I completely agree with you. We've absolutely got to grasp that opportunity. Yeah. Shall we ask Janet quickly? Tell us about the chat.
Thanks, Helen. The chat's been a little bit more quieter than before, but I think that's because people are just really tuning into the slides and the content, and people have said, fantastic, thank you, that's been really, really helpful. We've got an Elaine here, and she said, really insightful talk, Mark, thank you. Given the challenges, how can we incentivize the world to collaborate on care systems? And I think you've tried to answer that all the way through this presentation, but I don't know if you've got any final thoughts on that, Mark?
Yeah, I have got two different thoughts. First of all, I had the privilege to go to Davos each year, and the World Economic Forum was created in the 70s by countries and industry getting together and putting money into a pot to look at the pressing economic challenges. I mean, it's broadened its scope since then. Equally, if you think about countries now, the World Health Organization or the World Bank, countries are quite happy to put money together to either eradicate disease or alleviate disease, or indeed to look at investment funds around the world. Because all health systems are struggling, perhaps with the exception of Switzerland. But I really think government should put money into a pot so we can design what adapt and adopt very quickly. Now, I know there are cultural differences between countries, but these changes, as I've said, are tectonic and they are truly global. The trick is, of course, to have a great leadership capability that translates that locally in Birmingham, Bury, Blackburn, Bournemouth. But I think we should keep pressing industry with government and NGOs to create this global organisation. It's federated to make sure that good ideas come very quickly. I'm pretty passionate about that.
Brilliant. Fantastic. And I suppose just moving on from that, a lot of people have talked about open ways of connecting with people through technology and valuing people in terms of the work that you mentioned beforehand. So I think there's been some really great insights being shared on the chat room, a lot of activity here.
Yeah. So that's great, and what we'll do is we'll make the chat available, and Mark, we'd love you to see the chat as well in terms of what reactions we're getting, what people are saying. I think we should, I think we should kind of draw things to an end now. And Mark, that was an absolute tour de force, and I think keeping people engaged as a virtual speaker for 90 minutes is really tough. And yet you did that, and you'll see when you get to the chat box just how positive and how much people have enjoyed things. And it was interesting because before we had the talk today, we were publicising that the talk was going to happen on social media, and one of the comments we got was from Lee Spokes, whose Twitter handle is "Hello, my name is Lee." And he said about your book, he said, other than Lego, this book was my favourite Christmas present. All the world's views without the hours spent in airports. And I think, what you've given us today, Mark, is a real gift of, insight and wisdom and reflection. And I think, an even greater determination that we have to learn from each other. And I think, again, what you were saying, 85% of our time we spend on transactions. And yet, if we just spent a little bit of that time, connecting up with each other and learning and sharing, that we could move things forward. So I just want to thank Mark and his team at KPMG and the Horizons team for making it happen, and to thank everybody who's taken part today and made that such a lively and interesting talk. We will be making the recording available later, so look out for that. And what we'll also do is we'll advertise that on social media and on the Edge. And we've got a tweet chat happening on this topic next Wednesday at 4 o'clock UK time. So I hope that you will join in with that as well. So really great Edge talk, and have a great weekend, everybody. And hope that we can connect again soon.
Thank you, Helen. Lots of love. Bye bye.
Bye, everybody. Bye.